before I shut myself out of the thing. So, and hand it over to both of you. I say thank you to Organization for Rare Diseases India for providing this platform for us. So welcome to Dr. Andari Urtis Beria, who's moderating today's session, who is there with his logo of Myology Sans Frontiers, which and the director of the summer school and from Myology, Institute of Myology. And thank you, Dr. Rogin Foley, for graciously agreeing to speak of her experience with collagen 6 for only 2 decades, only 20 years experience with collagen 6. So on to both of you. Thank you for being here. Thank you.
Thank you, Anne. Well, it's okay. Welcome, Reagan. It's a pleasure. I think we met last time in Portugal somewhere.
In Barcelona.
No, Barcelona, Spain. Yeah, that's right.
Yeah.
And we had a nice conversation at the time. So you're a senior neuromuscular specialist, particularly involved with and without Karsten, because I know Karsten Berneman now left for Memphis. He was your mentor. And altogether, you did a wonderful job on collagen 6 related disorders. So we are looking forward to hearing you and to have the latest news about that. Thank you very much, Regan.
Thank you. Thank you so much. Let me share my screen and make sure you can see it okay.
Yes.
Okay, great. You can see that. You can hear me fine?
Yeah.
Okay, great. I'll keep an eye on the time. I think I'm aiming to leave plenty of time for questions, and I'm hoping to be comprehensive in the review of the collagen 6-related dystrophies, but very importantly, comprehensible. And so and hopefully at the end we'll have a chance for a good discussion. So the title of my talk is a collagen 6-related dystrophies, phenotypes, genotypes, and clinical trial readiness. Nothing to disclose. So the congenital muscular dystrophies were actually first described in London at Great Ormond Street Hospital, where both Dr. Ann Matthew and I trained and worked by a very famous neurologist, Dr. Frederick Eustace Batten. And his description from 1904 is still really on point. He described the congenital muscular dystrophies as, he said, the disease is congenital or starts early in infancy and is characterized by smallness, lack of power, and loss of tone in all the muscles of the body without localized atrophy or hypertrophy of individual muscles or groups of muscles. Very accurate, but even more on point and kind of more striking in its kind of accuracy is the point that he makes that the child usually learns to talk at the normal age and intellectually is often in advance of his years, which is true. And again, I had the opportunity to work at the same hospital with Anne really over a century after Dr. Frederick Eustace Batten. So the congenital muscular dystrophies are both clinically and genetically heterogeneous group of disorders, and they're characterized by congenital onset of weakness and hypotonia. We say congenital because that's when we first observe it, but truly this is a process that's going on prenatally. Most mothers will report that they really sense a decrease in fetal movement during the pregnancy. So really it's already ongoing. And then we notice the symptoms at the time of birth. Some families don't notice the immediate symptoms, but typically there are symptoms there at the time of birth. And the condition is associated with dystrophic appearing muscle. So here on the left is a muscle biopsy from a patient with congenital muscular dystrophy, and you see evidence of lots of fibrous tissue, but also importantly, you see degeneration and regeneration of muscle fibers, which is the classic formal definition of a dystrophic muscle biopsy. You often can see also increase in adipose tissue. So when you see increase in adipose tissue fibrosis and a dystrophic appearing biopsy in a child with congenital symptoms, really that fits the formal definition of a congenital muscular dystrophy. In 1930, Professor Otto Ulrich in Germany described what he termed this kind of atonic sclerotic muscular dystrophy. And his description is also very accurate to this day. And these are photos from his initial publication. And really what he noted was this kind of a unique combination of hypotonia and muscle weakness, as well as contractures of the proximal joints, which you can see even here, if you notice a little bit of anterior rotation of the shoulders, because the pectoralis muscle insertion has a tight kind of tightness. And so there's an anterior rotation of the shoulders. There's torticollis. You can appreciate with a little bit of elbow contractures here. There's some knee contractures contractures, but there's also this profound and really striking distal joint hyperlaxity in combination with these proximal joint contractures, often the torticollis, kyphoscoliosis, hip dislocation or dysplasia, and abnormal positioning of the hands and feet related to the hyperlaxity, the striking distal hyperlaxity. This was a description in 1930, but it was not until 2001 when Enrico Bertini and colleagues in Rome described that it was discovered that there's a decrease in collagen-6 expression in the muscle of these patients, and in fact, recessive, initially reported as recessive causative variants in the collagen-6 genes was discovered to be the genetic etiology of Ulrich congenital muscular dystrophy. What is collagen-6? Well, it's an extracellular matrix protein, and it's a quite complex in its assembly. It's a heterotrimeric monomer. So the three chains, alpha 1, 2, and 3, come together to form the monomer. And the monomer is encoded by three different genes. So COL6 alpha 1, COL6 alpha 2, and COL6 alpha 3. Intercellularly, the collagen-6 monomers align in an anti-parallel fashion to form dimers, and then these dimers align laterally to form tetramers, and then these tetramers are secreted extracellularly. But importantly, the extracellular matrix expression of collagen-6 is not just for skeletal muscle, it's also for blood vessels, nerves, skin, tendons, cartilage, intervertebral discs, lenses of the eye, and internal organs. So really, it's an important extracellular matrix protein. For the muscle, we like to call that the myomatrix, the extracellular matrix of muscle, we call the myomatrix. You can see where collagen-6 lives here outside the sarcolemma. You can see dystrophin here, and here's collagen-6, part of this extracellular matrix, a supportive structure of the sarcolemma. Now, in 1976, our colleagues in the Netherlands described what they thought was a kind of a myopathy, initially described as autosomal dominant, and they termed it Bethlem myopathy. And it was really characterized by flexion contractures of the fingers, long finger flexors, the wrists, the elbows, and the ankles, with symptom onset described typically during the first or second decade of life. But it wasn't until 20 years later, in 1996, that our Dutch colleagues discovered that indeed collagen-6 causative variants were the genetic causation for Bethlem myopathy. And then in 1999, they described that actually there were evidence and symptoms of hypotonia. You can see here slip through on vertical suspension and W sitting in children that ultimately manifested in adulthood Bethlem myopathy, but really had some earlier signs and symptoms of hypotonia, and it could even have some hypotonia and torticollis. So really a wider spectrum than initially identified as a more adult onset myopathy. Over time, we've changed the nomenclature, and we really kind of pitched the idea that this should be termed Bethlem muscular dystrophy, because in those patients who had sequential muscle biopsies, the biopsy always progresses to a dystrophic histology. So truly it is also a muscular dystrophy. So we're now calling it Bethlem muscular dystrophy. And here are some classic photos from courtesy of Kate Bushby, who used to work in Newcastle. Really kind of a striking clinical picture. Once you see a patient like this, you won't miss the diagnosis. So with Bethlem muscular dystrophy, again, a little bit of anterior rotation of the shoulders, the elbow contractures. And here we call this kind of the praying hand signs, where they are unable to keep their hands together and their elbows flexed, because there is elbow contractures, but also long finger flexor contractures, which are really only appreciated when you have the wrist in a position of extension. So if you're just looking at in neutral, you can't appreciate the long finger flexor contractures, but if you extend the wrist, you'll realize there are long finger flexor contractures and often very striking and severe Achilles tendon contractures. So when I landed in London and I met Dr. Ann Matthew, we had known and had been described in literature that the ends of the spectrum of the phenotype as Ulrich congenital muscular dystrophy and Bethlem muscular dystrophy. But we found a lot of colleagues were were diagnosing patients as having either severe Bethlem or mild Ulrich. And really, they were trying to describe this intermediate category, and recognized that it was going to be important for us to really delineate the patients that fall in the intermediate category. So looking at a large cohort of patients, 145 patients, international data that I reviewed when I was in London, we were able to kind of define patients initially off of the motor milestones. And those patients that either never walked or lost ambulation by 10 years of age clearly fell into the Ulrich congenital muscular dystrophy group. And in that group, the forced vital capacity declined by 2.6% per year, and an average age of onset of non-invasive ventilation was necessary by 11 years of age. And that number is consistent from this international cohort, a UK-specific cohort, a Japanese cohort, so very clear for the Ulrich patients. But then we looked at the rest of the patients that were not falling in the Ulrich group, and those patients who didn't achieve the ability to jump or run, we kind of looked at them as an intermediate group. And then in diving deep into their motor function, those patients walked much longer than the intermediate patients, but they lost ambulation in the late teenage years. So they were clearly different than the Bethlehem patients that walk until adulthood and may need a walking aid in 40s and 50s. But most importantly, for proactive respiratory care, the patients in the intermediate group have a decline in pulmonary function that starts slightly later than the Ulrich patients, but is consistent. So a rate of decline by 2.3% per year in forced vital capacity, and a need for non-invasive ventilation by approximately 21 years of age. So recognizing this cohort as being intermediate is important for proactive, sufficient, careful respiratory care. The Bethlehem muscular dystrophy patients in this evaluation we had done internationally, which is retrospective, some patients needed BiPAP, non-invasive ventilation in the form of BiPAP around age 40 years, but it wasn't statistically consistent in the cohort of Bethlehem muscular dystrophy patients. But really it is a spectrum, a continual spectrum, but important to recognize the extremes as well as the intermediate phenotypes. So we decided that while it was good to have retrospective data, it would be best of all be able to tell parents in the clinic what their child's future phenotype would be, so we can really appropriately be proactive in our care. Will the child have Ulrich or intermediate or Bethlehem? So working closely with my colleague Daniela Terra de Benito from Barcelona, we did a combined cohort of 119 patients, 54 from Spain, 65 from the US, and we looked at the data retrospectively. And we looked at maximotor milestones, ones that were clear, because Danny had recognized that asking parents about jumping and running is very subjective. Parents may say a child may jump, we may observe that jump and realize it isn't actually a jump. And so how can we actually qualify or kind of look at the maximotor motor milestones in a really kind of clear way? So we decided to use a couple milestones, one being the ability to rise from the floor unassisted, meaning if the child's in the middle of the room and there's no chair nearby, no parent nearby, can the child arise on their own? They can use a Garage maneuver. That's still considered unassisted. So they're using their own body, get off the floor alone. That's a motor milestone. It's important. And then also the ability to climb 4 steps without holding onto the railing. And these maximotor milestones by age 5 years could distinguish between the 3 phenotypes. So those patients who could only arise from the floor with assistance, meaning they needed to crawl over to mom and dad to pull up or over to furniture to push up, those patients by nature of their proximal muscle weakness and their contractures could not arise independently from the floor. They would have a phenotype of Ulrich congenital muscular dystrophy. And this probabilistic approach is quite consistent, not perfect, but quite consistent. Those patients who could arise from the floor unassisted, meaning with the Garage maneuver as their maximum motor milestone, but could not arise or ascend 4 steps without a railing, those are intermediate patients. And those patients who can ascend 4 steps without a railing by age 5 years are really the Bethlehem muscular dystrophy phenotype. And then looking at, as you see here, the forced vital capacity and using this probabilistic approach, it really shows that indeed the Ulrich patients have a consistent decline in forced vital capacity. Intermediate have a little bit of a delayed onset of decline, but also a consistent decline with the need for non-invasive ventilation, where less of a pattern with the Bethlehem patients. And then also with the percentage ambulating, intermediate patients will stop ambulating at a later age, late teenage years, whereas the Ulrich patients are stopping ambulation by around age 10 years consistently. So it's been really helpful for us to help guide our colleagues when they reach out and say, how do I guide parents for their toddler? What's the future phenotype? And most importantly, how careful do you need to be about the proactive respiratory care? And any patient in the Ulrich group, intermediate group, you cannot be too careful and proactive with monitoring pulmonary function. So for the diagnostic algorithm for the collagen-6-related dystrophies, we use, if we have muscle tissue, muscle biopsy, we often use dual immunofluorescence imaging. So we stain collagen-6 and we'll stain another basement membrane protein, often perlecan, and in a normal muscle biopsy, the immunofluorescence would show you that the collagen-6 and the perlecan co-localized, so completely merged. But in a collagen-6 patient, the patients are typically still producing collagen-6, but the protein is produced in aberrant conformation. So it does not co-localize as it should to the basement membrane. It's not co-localized with the perlecan. So here you see the perlecan at the basement membrane, but the collagen-6 here is green, is interstitially kind of it's secreted but not co-localizing at the basement membrane where it should be. So if you see mislocalization of collagen-6 on immunofluorescence, that can be exceedingly helpful. And you know you're looking at a patient with collagen-6 related deficiency. If you have the ability to do confocal microscopy, it's even more profound. So here we have a confocal image of a patient with collagen-6 related dystrophy where the collagen-6 here is red and the green is perlecan. DAPI is for the nuclear staining, and you see that the collagen-6 is not co-localizing with the basement membrane. So again, a clear picture of collagen-6 related dystrophy. And what's so interesting and so profound is that, based off of the initial description in 1930 from Professor Otto Ulrich, these are photos that have been generously shared by parents of patients of ours at the time of birth. So soon after birth, when they're being weighed and washed, you can see here there's evidence of torticollis. And you can see a little bit here of some distal hyperlaxity. Here you can see this classic positioning of the foot with the dorsum of the foot against the anterior surface of the shin. So this positioning is classic for collagen-6. So these findings are very much profound and seen at birth. These are other photos that are shared by another family patient of ours. And mom and dad said that their son looked like a bird when he was born. So you notice the elbow contractures here, the anterior rotation of the shoulders, the distal hyperlaxity, the hip contractures, kyphoscoliosis. We had the opportunity and privilege to see this patient 2 years of age in clinic, and here he is. He has kind of some classic findings of Ulrich muscular dystrophy. So you see we often talk about a round or a kind of angelic appearing face, prominent ears, skin findings. You see keratosis, pillars on the extensor surface here of the arm. You see a scar here, which we call atrophic. It used to be called in literature cigarette scar paper from the team in London, but we call it now more atrophic. You can see either atrophic scarring, which is kind of white and flat, or hypertrophic keloidal scarring, because collagen-6 is produced in the skin, and healing the aberrantly formed collagen will form abnormal scars. Here you can see prominence of the calcaneae. And here I can assure you he was not in pain when we took this picture. You can see distal hyperlaxity. So pretty profound distal hyperlaxity. And you can see here also distal hyperlaxity of the foot, dorsiflexion against the shin. So we have looked at, international cohorts of patients. We also dug kind of into our own cohort of patients we've been following here at the NIH, looking particularly at 17 patients whom we had deeply phenotyped, and we see that really all had symptoms at birth. More than 80% have clear symptoms at the time of birth: hypotonia, proximal joint contractures, distal joint hyperlaxity, abnormal positioning of the hands and feet, hip dislocations, often called dysplasia, and prominent calcaneae. And in our cohort, by 7 plus or minus 2.6 years, most children needed to use a wheelchair for ambulation. And in our cohort, because we're particularly proactive about the pulmonary surveillance, most of our patients started non-invasive ventilation at like 8.9 years plus or minus 2 years. So a little bit earlier than the international cohort, because that was a large international cohort with different centers having different thresholds for starting non-invasive ventilation, but we're pretty proactive with our patients here. So looking at the motor function, Ulrich muscular dystrophy, independent ambulation is usually the most advanced motor milestone achieved. Some patients only acquire the ability to walk on their knees. That's quite also kind of a striking finding and suggestive of collagen-6 related dystrophy. In those patients that achieve the ability to ambulate independently, loss of ambulation as defined by full-time wheelchair dependence occurs between 10 and 11 years of age. Again, that was what we saw in our large international cohort of patients I studied in London, as well as a prior UK-specific cohort. So that 10 to 11 years is really when guiding families is a time when ambulation is typically lost. Pulmonary function over muscular dystrophy in the UK-specific cohort, the onset of non-invasive ventilation in the form of bilevel positive airway pressure, or BiPAP, was 14.3 years of age. In the international cohort I studied, the Ulrich patients, which numbered 75, the onset of non-invasive ventilation was 11.3 years of age, which is similar to the Japanese cohort, so kind of more consistent. This is probably also a time when there's less recognition of the need to be proactive. And sadly, in my review of the notes of the UK cohort, there were 3 patients who sadly succumb to respiratory infection in the setting of unsupportive respiratory insufficiency. So it had noticed a need for BiPAP. It had not been initiated, and it succumbed to respiratory infection. So quite sad. So from noticing that from the retrospective review that I did, I've been extraordinarily proactive with all of our patients and make sure they know to be ahead of the curve and start pulmonary function surveillance and be on BiPAP in the older patients by 10 or 11 years of age. For the intermediate patients, they can have congenital symptoms, and the infants usually attain the ability to rise from the floor without assistance. There's progressive muscle weakness and joint contractures leading to a loss of ambulation by about 19 years of age, and a decline in pulmonary function occurs in all patients uniformly, a little bit later than the Ulrich patients, but needing to be on BiPAP by around late teens, 19 or age 20, often while some patients remain ambulatory. So very important to be cognizant of the need for BiPAP, even while some intermediate patients may still be ambulatory. Here's an ambulatory patient we saw at 17 years of age. So some evidence here you can see of elbow contractures, long finger flexor contractures. Often intermediate patients do not develop scoliosis, but often have a rigidity of the spine. So here's a rigid spine, which kind of protects towards scoliosis. So he's fortunate in that sense. And he's demonstrating for us the distal hyperlaxity. So the contractures, the hyperlaxity, and he was ambulant for short distances at 17 years of age. So when we talk about clinical trial readiness, in general, we need to think about, I think, 3 major pillars, and one of them is studying the natural history of conditions. And when we study natural history, we need to study the entire range of clinical severity. We need to deeply phenotype and study all systems that are involved. Anyone who's done clinical trials in gene therapy knows we're seeing things after therapies that were not recognized in the natural history studies. So we need to be comprehensive in our natural history studies. We need to have a good sense of natural history so we can enable clinical trials to be powered with lower numbers. So when I think of like 3 pillars of clinical trial readiness, the first is study natural history. We also need to identify outcome measures and optimize clinical care. But diving into natural history, we also need to have profound and well-studied natural history to be able to recognize or in a clinical trial a change in the disease course, to say this is different than natural history, therefore proving that this therapy is effective or efficacious. So in that same international study I did in London of 145 patients total, I was able to define the statistically significant decline in forced vital capacity in the patients with Ulrich Genomuscular Dystrophy, 2.6% per year, intermediate patients 2.3%, and not a significant relationship in the Bethlehem patients. But very, very importantly, we decided to focus in on an age range where many patients would be involved in clinical trials between 5 to 15 years. And we realized it's really a stepwise type of progression and decrease in pulmonary function, because if you look between ages 5 to 15 years, it's actually a steeper decline in pulmonary function. Patients were declining by 3.5% per year, and they were in that same age range. Intermediate patients were only declining by 1.7% per year. So it's not a straight line. It's definitely always progressive, but recognizing different age ranges may have age range specific rate of decline, which is important for clinical trial preparation. We published this work in 2013. It's also really important to think of the genetics of COL6-Related dystrophies because it's quite complicated. Initially, it was described that Ulrich was dominant and Bethlehem was recessive, but indeed, very importantly, autosomal dominant and autosomal recessive inheritance can result in Ulrich and Genomuscular dystrophy intermediate, COL6-Related dystrophy, and Bethlehem muscular dystrophy. De novo dominant negative causative variants are the most common mutational mechanism for the COL6-Related dystrophies. The most common. It's important if you can do parental segregation testing to confirm it's de novo, but it's the most common mutational mechanism. Digenic inheritance, meaning causative variants in different collagen 6 genes, has not been observed. So we have not seen patients with a variant in COL6 alpha 1 and maybe one COL6 alpha 3 that are together causative. No, it's always been in one of the COL6 genes that the mutational mechanism occurs and is causative. Very importantly, parental somatic Parental somatic mosaicism is very important to think about and to make sure you don't miss. And so it's not uncommon in the COL6-Related Dystrophies that a parent may not recognize that he or she has subtle symptoms. So if the parent will consent to doing a muscle MRI, as you see here, we have a patient and we have the mosaic parent. The muscle MRI pattern is striking and highly suggestive of collagen 6. So we have here in the rectus femoris, you have a abnormal signaling in the center of the rectus femoris, and the outside in pattern and the vastus lateralis. That's a classic suggestive. It's a very sensitive finding, not 100% specific, but very sensitive finding for COL6-Related Dystrophy. So make sure you consider somatic mosaicism, especially if the genetic testing result is suggestive of somatic mosaicism, and make sure to phenotype the parents, because that will be very important for your genetic counseling for patients. And again, it is not uncommon for somatic mosaicism to occur in the COL6-Related Dystrophies. What type of variants are pathogenic associated with autosomal dominant inheritance in the COL6-Related Dystrophies? Well, there is often in-frame exon skipping. So in contrast to Duchenne muscular dystrophy, these are in-frame exon skipping. So you can get a splice site variant or in-frame deletion. That's often a de novo dominant mechanism as causative in the COL6-Related Dystrophies. And these dominantly acting skippings often occur in the N-terminal region of the triple helical domain. So here, denoted by TH, triple helical domain is a domain where a lot of the causative variants occur, and the N-terminal region is an important region because the protein assembles from the C-terminal region to the N-terminal region. So if you have a variant in the TH triple helical domain that's past this really essential cysteine residue, this residue enables the 3 chains, alpha 1, 2, and 3, to come together and bind. If the variants in the N-terminal region, you will not prevent the monomer from forming, meaning any abnormal formed chain will be part of the tetramer. So be included, have a dominant negative kind of effect, domino effect for the formation of the tetramer. So other common dominant negative variants are heterozygous single amino acid substitutions that disrupt this glycine XY motifs in the highly conserved, again, region, triple helical domain, this N-terminal region. These glycine variants are common. So glycine variants, exon skipping in the TH domain. If you look online to LOVD, the Leiden Open Variant Database, and you're seeing that your variant is in the TH domain, and we have defined exons for the TH domain for the 3 collagen 6 genes, you can be more confident that it's probably causative, especially if it's de novo. So de novo dominant is a very common patient mechanism. So for pathogenic variants that are associated with autosomal recessive inheritance in the COL6-Related Dystrophies, most of these are nonsense or frame shift, and some variants result in the actual absence of collagen 6 due to nonsense-mediated decay. It's more rare, but of course, if they're biallelic nonsense variant in the collagen 6 genes, typically it's going to be a very severe phenotype. It's going to be a severe Aldrich phenotype because there is no collagen 6 protein produced, in contrast to aberrantly formed collagen 6 protein. Intragenic deletions and splice site variants can result in out-of-frame transcript or chain, which also is assembly incompetent. So it is complex to interpret variants in COL6-Related Dystrophies, but you have some other tools at your disposition that can be really helpful. And I'll talk about later, but very importantly, muscle imaging, and if you have muscle biopsy, they can be hugely helpful hints, in addition to the clinical picture, which in itself is highly suggestive. It's important to recognize that haploinsufficiency for the collagen 6 genes does not result in collagen 6-Related Dystrophy. We had the opportunity to study some patients where one parent carried a deletion here in the COL6 alpha 2 gene, and the other allele child inherited a variant in the same region, which is deleted on the other allele. So when you get the report, it looks like it's apparently homozygous, but indeed it's a deletion in combination with a causative variant in the other allele. In this case, it was a deletion, COL6 alpha 2. The other allele was a large deletion encompassing COL6 alpha 1 and 2. The most important lesson here is the carrier parents for these deletions do not have a clinical picture of collagen 6-Related Dystrophy. And we published this in 2011. It became really groundwork for our therapeutic approaches, meaning we can do allele-specific silencing. A child who has a dominant variant, if we silence that allele, we know that because any parent carrying a deletion of COL6 genes does not manifest a clinical phenotype, we recognize that haploinsufficiency of the collagen 6 genes does not result in the disease. So we can use allele-specific silencing and silence the mutated allele and have a normal clinical phenotype. So again, the therapeutic approaches include allele-specific targeting appropriate for the dominant and dominant negative variants and can be designed for antisense base molecule siRNA or ASOs. And we know this would be okay because haploinsufficiency does not cause disease for the COL6-related dystrophies. Very importantly, Yachin and our team had defined in 2008, it's the muscle interstitial fibroblasts, which are the main source of collagen 6 synthesis in skeletal muscle. So that's very important because we need to deliver any therapeutic to these muscle interstitial fibroblasts. They're now called FAPS, fibroblasts. That are muscle interstitial are now called fibrodipogenic progenitor cells or FAPS. These are what produce and secrete collagen 6. And so these are the resident multipotent, as they call, stem cells of the muscle. And our therapeutic strategies need to account for this, deliver any genomic correction to the fibrodipogenic progenitor cells, making sure we're testing our animal models for delivery of the therapeutic to the FAPS. So why do I bring up this compound here? So omega-pill is a small molecule. It's an anti-apoptotic molecule that had been tested in ALS, a large international trial, and Parkinson's disease. It had been found to be safe in adults, but not effective in Parkinson's and not effective in ALS. And we know from our mouse models from collagen 6, the alpha-1 null mouse, and from 2 mouse models for Mersenne deficient or Lambert-related congenital muscular dystrophy that apoptosis is a common pathomechanism for collagen 6-related dystrophy and for Lambert-related dystrophy. So omega-pill really inhibits apoptotic cell death by inhibiting the GAPDH nuclear translocation. And this compound had been acquired from, had been with Novartis and acquired by a company called Santhera Pharmaceuticals, who reached out to us to inquire about the potential of using this small molecule as in a therapeutic or a safety and pharmacokinetic study. So again, omega-pill reduces apoptosis by reducing the p53-dependent apoptotic cell death pathway and increasing levels of anti-apoptotic BCL2. We had some unpublished data from Professor Paolo Bonaldo in Padova in the COL6 alpha-1 knockout mouse that demonstrated decreased apoptosis in mice treated with omega-pill, this oral compound. In particular, the diaphragm had decreased apoptosis and then some improved skeletal muscle mitochondrial integrity. Some data, but not very robust per se. There was more robust data in 2 mouse models for LAMA2, the DYW and the DYJ. In the DYW mouse model, omega-pill improved survival, improved locomotor activity, and it also inhibited apoptosis in the muscles. So we had some data in both mouse models, and that was proving to be effective in decreasing apoptosis. So we here at the NIH had a single site phase 1 study. We called the CLISTO study, or congenital muscular dystrophy ascending multiple dose cohort study, analyzing pharmacokinetics at 3 dose levels in children and adolescents with assessment of safety and tolerability of omega-pill, this oral apoptotic compound. It was a phase 1 study. It was open label, sequential group. It was a study of pharmacokinetics and safety for LAMA2 and COL6 dystrophy patients. So we used an adaptive trial design to really carefully be able to arrive at dose adjustments with a small cohort. So it was a total of 20 patients, 10 with COL6 dystrophy, 10 with Lambert-related dystrophy between the ages of 5 and 16 years. And we had initially written the protocol with some pre-specified doses. The low dose was supposed to be 0.02 mg per day, and we had a very careful design where we had cherry syrup vehicle, just cherry syrup for a month. Then we did cherry syrup with the omega-pill in the syrup. We did PK on day 1. Patient came back 4 weeks later, PK. We discussed all the PK profile with the Day Safety Monitoring Board. We used this continual reassessment method, a statistical method, to see if we were achieving pharmacokinetically the goal area under the curve. And before we proceeded to the next cohort, we wanted to make sure it was safe and with appropriate PK profile. So the low dose went well. The middle dose, we encountered that actually the middle dose, which was 0.08 mg per day, was actually exceeding sometimes our goal pharmacokinetic profile. So we went back to the drawing board and we changed this continual reassessment method to another analytical method. It's called stochastic approximation with virtual observation recursion. This statistical method allowed us to interpolate doses and not have to use a pre-specified dose in order to achieve the best dose to get at the pharmacokinetic goals. And so we went back and we adjusted the dosing down to 0.04 mg per kg per day, and then went up to 0.06 mg per kg per day. And we realized this actually was a very good dose for us to arrive in the goal pharmacokinetic profile. And so we had 8 patients treated at this goal dose of the 0.06 milligrams per kilogram per day. And this adaptive dose finding method really allowed us the identification of a dose associated with a target. So this, you can see here, this 0.06 associated with the target area under the curve with high statistical accuracy using a relatively small sample size. And so we did not want to exceed the goal area under the curve, but really be on target. And 0.06 was really where we need to be. So the adaptive dose finding method was really essential. It assigned a higher portion of the trial participants, really 40% to the target dose, enabling thus like a safe and efficient means of dose finding in medically fragile patients. So this study really was important for us to tell regulatory agencies we can successfully recruit and run a clinical trial in these rare diseases. Collagen 6 and Lambda 2 collectively have an incidence between 0.5 to 0.9 per 100,000, so really orphan diseases, and we were able to show that we can run phase 1 studies for these patients. So we had the opportunity from this study to prove that recruitment and running the trial is really feasible. We were able to assess safety and tolerability of Megapill. We proved it was safe and tolerated in patients with COL6-Related Dystrophy and Lambda 2-related dystrophy. We were able to really understand the pharmacokinetics and the potential for or a lack of accumulation of a Megapill. And we were able to also get some exploratory outcome measures. We did grayscale muscle ultrasound. We did some specific sequences of muscle MRI. We called our CMD sequences with Dixon sequences. And we also collected biomarkers before, during, and after exposure to a Megapill using serum and urine. The challenges of the study were that the standard of care, namely initiation of non-invasive ventilation, was not achieved in all patients at the time of patients coming to us to enroll. So what we had to do was, recognizing low pulmonary function, low forced vital capacity, we had to start many patients on BiPAP during the course of the trial, which is not ideal. So you don't know, was the exposure to a Megapill improving their pulmonary function, or was it the BiPAP initiation? So it underscored for us the need for really standard of care of patients before enrolling in a clinical trial. We had done pulmonary function testing every single study visit, but it was difficult because the children were tired. They didn't give a good effort. We couldn't figure out, was their pulmonary function really decreased? We would do a pulmonary function at 4 p.m., repeat the next morning at 7 a.m. It was drastically different. So energy and stamina during the study visit was important to also giving us accurate pulmonary function testing. So we don't typically check pulmonary function every month, so it's hard to interpret the noise versus actually true trends in pulmonary function. We also recognize that children can get really, tired during pulmonary function assessments and also physical therapy assessments. So obviously making sure that we pace ourselves and the children don't get worn out during the study visit. We want accurate assessment of function. And importantly, for this study, the sponsor had an extensive list of contraindicated medications, and also, including also chocolate and caffeine that could not be taken during the 12 months on the study drug. And many children were in the study during Halloween and couldn't eat chocolate. So it was a lot to ask of a child, not to ask of our teenagers who wanted to drink coffee to not be on those when on the medications. That was hard for a lot of participants. Obviously, it takes a village to run a trial. Even though it was 20 patients, it was extensive study visits. And so our team at the NIH really came together as a little village to run the study. We had wonderful collaborators, Ken Chung at Columbia University was our statistician with these adaptive trial designs. We have a colleague at University of Pennsylvania who was helpful with the pulmonary function interpretation. Our trial design and our DSMB chair was Professor Francesca Montoni from Great Ormond Street Hospital, UCL, and we had funding from many sources, including Cure CMD, really gave the seed funding to enable us to launch the trial, and the drug was supplied by Santhera with support from the FDA and EndoStem Consortium. So I just kind of to add that this study was supposed to go into a phase 2, but in light of the fact that we didn't have robust animal model data for the collagen 6 mouse model, and we didn't have defined biomarkers, we didn't meet the mark for being able to launch a phase 2 study. So we had to go back to the drawing board to get more data, both from the animal model and for biomarkers. Simultaneously, we were also analyzing some patients who we had seen that have a clinical phenotype of Ulrich and congenital muscular dystrophy who had been a mutation or causative variant negative. We included 4 patients, 2 of my patients that I had seen in the UK, 2 patients in the US, who again had a clear clinical picture of Ulrich muscular dystrophy and muscle biopsies. And in collaboration with the Broad Institute, we did RNA sequencing, and we compared the RNA sequencing to control muscles. And you can see here that these 4 patients all had the same Shishimi plot. Here you can see the same highly recurrent de novo variant in deep intronic variant on intron 11, which caused the insertion of a pseudoexon. So very strikingly, 4 patients we chose undiagnosed genetically, couldn't find the variant, all had the same exact deep intronic variants. That for us, that was a really important finding. We published this with our colleagues from the Broad in 2017. A colleague in the lab, Dr. Veronique Beauduc, then worked to use antisense oligonucleotides to skip that pseudoexon. And indeed, we can actually skip the pseudoexon, resulting in a normal collagen 6 alpha 1 transcript. So unlike in Duchenne muscular dystrophy, when you skip an exon, you have a truncated protein, we're actually getting a normal collagen 6 transcript. And so very promising because it is very highly targetable variant, and it's also highly recurrent. So the phenotype is really one where you will see, if there's muscle biopsy, you will see the collagen 6 mislocalization. You will see the classic muscle MRI imaging findings for collagen 6. You will see, unlike classic Ulrich muscular dystrophy, you actually see a striking paucity of neonatal symptoms. So no real congenital phenotype, followed by maybe delayed onset of intermittent ambulation by 1 year age, and then accelerated progression to a severe Ulrich muscular dystrophy phenotype. So the first step is recognizing this clinical phenotype and ensuring that you molecularly confirm this deep intronic variant, which can be found on whole genome sequencing and whole exome sequencing, but on the classical Sanger sequencing, because this variant is deep in intron 11, it had historically been missed. So you want to make sure that we first recognize patients, confirm molecularly they have this deep intronic variant, and then also establish the natural history of this intron 11 cohort. We've been able to recognize 44 patients internationally and study them in detail with this deep intronic variant. Subsequently learned of 28 further patients, so 72 known internationally. It's now the most common recurring causative variant for patients with collagen 6-related dystrophy. And again, it's highly targetable. Very importantly, we had the opportunity to meet a patient who presented with somatic mosaicism for this variant, and she became really an in vivo example of our therapeutic approach. So here you see the patient. You can see on skin fibroblast, skin biopsy, and blood that she's not fully heterozygous for the C-to-T change. So she has a proportion of her cells which have the C-to-T change. So she's a somatic mosaic, and her clinical phenotype really is that by age 9 years, she's able to maintain the ability to ascend and descend stairs without holding onto the railing. So a Bethlem muscular dystrophy phenotype. Her pulmonary function is very good, 91% upright, 79% supine. So in contrast to the other patients that are complete heterozygous for this variant, this patient is one with Bethlem muscular dystrophy. And you can see here too, here she is percentage of T allele, the fractional percentage of T allele versus patients that are fully heterozygous. So much less burden of the causative variant in her cells. And then as a result, an amelioration of the Ulrich congenital muscular phenotype to Bethlem muscular dystrophy, truly an in vivo example of our in vitro and mouse work to skip this pseudoexon. Again, very importantly, the muscle imaging in the heterozygous patients, the classic collagen 6-related dystrophy imaging findings in the mosaic patient, much less affected. In muscle ultrasound, you can see is in the rectus femoris, you see this central cloud phenomena, similar to what you see in the muscle MRI. So increased echogenicity of rectus femoris, an outside-in pattern in the vastus lateralis, which you see in that muscle MRI. The mosaic patient has a bit of the pattern, but still maintains a bone echo. So less affected clinically, less affected on muscle imaging. So we're able to define the classic, in contrast to the classic Ulrich muscular dystrophy phenotype, the intron 11 patients really have first symptoms by around 1 year of age when they have delayed ambulation. That's when they first see the neurologist. So keep in mind, you may see a patient who has delayed ambulation who could have this intron 11 variant, but then the clinical phenotype progresses to be roughly similar to Ulrich muscular dystrophy with the onset of wheelchair dependence by about 8.5 years, plus or minus 3 years, and the onset of non-invasive ventilation in our retrospective data set about around 12 years. So again, later initial symptoms, but a progression towards the ulrich muscular phenotype, which shows us that we can use the same outcome measures that we use for classical overweight patients for this intron 11 cohort. We were fortunate to publish this cohort in Brain, and very honored that the editorial in September was about our variant-specific deep phenotyping as a tool for our precision therapeutics. So just to finish up, because I know I want to leave some time for questions, there are two other elements of clinical trial readiness: identifying outcome measures and optimizing clinical care. So just to summarize, outcome measures that you identify really need to be age appropriate, disease stage appropriate, reliable, reproducible, measure something meaningful, and are sensitive to change. So we had the opportunity here to study over the course of 5 different visits. So this 5 summertime study visits. We had 23 patients with COL6, 24 with LAMA2, and we were able to find the annual rate of change in the motor function measure 32 patients for COL6, and then from that we could actually do a sample size calculation to basically understand how we need to power our future studies, and realize that 12 patients would be needed to enroll from the COL6 cohort to detect stabilization of disease. So using validated outcome measures to study our patients are helpful to define the natural history, to also design our clinical trials, and to be able to know when we can detect a change from baseline, from the natural history of the disease. But most importantly, when we talk to the FDA and the EMA, we need to make sure we're talking about a minimally clinically important difference. Is our motor scale change important to the patient? If the MFM32 changes, does the patient care? Is it important? So we're now anchoring our changes in motor function and pulmonary function to what's important to the patient. So the minimally clinical important difference has been defined for the MFM32 in our patient population, and having definition for the MCID helps us to tell the regulatory agency, yes, our change on the motor scale is important to the patient. It's an important difference, and that will kind of give more weight to our therapeutic efficacy of tested therapies in clinical trials. Finally, exploratory outcome measures are also important: biomarkers, muscle imaging, and remote outcome measures. These are important as adjunctive data to give to the FDA and EMA when we're talking about a therapy and its efficacy. So just briefly to mention, when we look at biomarkers, they need to be disease relevant, potentially disease stage relevant. They should be capable of reflecting potential therapeutic changes. So without doing a muscle biopsy, can the biomarker, serum or urine, show us that we have a potential therapeutic change? And ideally provide a measure of disease and target engagement. So for congenital muscular dystrophies, we want, like, ideally we want fluid biomarkers or liquid biomarkers. Liquid biopsies, fluid meaning serum, is minimally invasive, is capable of being sampled repeatedly during a trial, and it may be analyzed by robust analyses. So in gratitude to the very deep generosity of the patients and their families, this is a picture taken at one of our Cure CMD international meetings of families and patients that gather together. When we see these patients, they often volunteer to give us urine and blood samples to assess disease-relevant biomarkers. Our challenge had been, how do we find controls? How do we find age-matched controls for young children? It's very hard to find blood samples from children that are not affected by disease. So I had the opportunity to collaborate with colleagues at the University College Cork in Ireland at the Infant Center, where they have in their biobank over 400 children who are not affected by disease, that have control serum samples and associated phenotype data in their infant center. And they have done discovery level microRNA discovery biomarker research in healthy newborns compared to children that have hypoxic encephalopathy. So they have basically the expertise in exploratory biomarker research and the age-matched controls. So I was fortunate enough to have a Fulbright award to ship our patient samples to Cork and use their controls and do exploratory microRNA and proteomics research with the support of 7 patient and family foundations, which together supported our research costs. We looked at a pilot cohort of 18 patients with COL6 and 14 with LAMA2 between the ages of 5 and 79 months of age. And we had fortunately had to use the same tubes to collect our serum, so really nice controlled. And this data is being analyzed, looking at the microRNA, looking at the proteomics. This analysis is in progress, but very promising for us to potentially have a liquid biopsy or a biomarker that could be used in future clinical trials. Because I want to leave some time for questions, I'm going to just kind of briefly end with optimizing clinical care. Very important topic. We want every trial participant to start from the same level of optimized proactive clinical care. We have written a gene review, which is open access, accessible wherever you are in the world, on your phone or a computer, where we've included very detailed information on the diagnostics, the genetics, the recommended expert care recommendations for the overweight patient, intermediate, and Bethel muscular dystrophy. So parents can bring that information to any local care provider, and the local care provider can say, oh, these folks have cited all literature on this. It's not just them saying this, but 25 other folks internationally have seen the same thing. So it gives the families more information available at their fingertips, so they don't feel that doctors are saying to them, I have no idea about this condition. The data is actually thankfully available. My last point is about proactive respiratory care. If there's one thing you take away from this talk, it is this: the diaphragm is inordinately weak in collagen 6-related dystrophies. That weakness is profound, and it's the extrinsic cause of restrictive lung disease and restrictive pulmonary function pattern. It's not the lungs. The lungs are fine. It is the muscles. It's the most common pattern in general muscle disease, and it's profoundly weak, the diaphragm, in COL6-related dystrophies. So we talk about proactive respiratory care is pulmonary function, upright and supine. That differential is going to be a surrogate measure for the degree of diaphragmatic weakness. Polysomnogram, as often as can be done, it's hard to do locally, but with pulmonary function testing, if the forced vital capacity is less than 50%, we know that child should be on non-invasive ventilation. We know a child with a 50% upright FVCs probably has a drop about 20% supine and is going to be hyperventilating in deep sleep. So the time initiation, non-invasive ventilation in the form of BiPAP is essential, as is, if possible, the use of the insufflator, exsufflator machine or cough assist machine to promote airway clearance. I call it the miracle worker. It saves kids from hospitalizations. It helps to expectorate phlegm before that phlegm goes from the back of the throat and becomes a lower airway or pneumonia. So insufflation, exsufflation every day for exercise to the chest wall. You can use up to every hour during times of respiratory infection. Often prevents pneumonia, prevents hospitalization. So again, really a miracle worker. And just finally, just to show you in comparison to controls, the LAMA2 patients have, the COL6 patients have minimum movement of the diaphragm, but they have really kind of hyperdynamic chest wall. So don't put a brace on these patients on their spine, because they're relying on the hyperdynamic chest wall to compensate for their minimal diaphragm movement. The opposite pattern is interestingly seen in LAMA2, where the diaphragm is great, but the chest wall is very restricted. So knowing that there are disease-specific patterns for the weakness of the respiratory muscles. Finally, just to acknowledge our team here at the NIH, who work together tirelessly, both in the clinic and also in the laboratory. As Andoni mentioned, Karsten just moved to St. Jude Children's Research Hospital. We're hoping to translate a lot of our preclinical work in the lab, including for our intron 11 patients, ideally to get that work translated to clinical trials. I want to acknowledge also a wonderful colleague of ours, Dr. Payam Mohassel, very involved in the COL6 alpha-1 mouse and some TGF-beta therapeutic approaches. He's now at Johns Hopkins. But most of all, I want to say we're looking at a promising future, and we're hopeful of translating our research into clinical trials for patients with collagen 6-related dystrophy. And I want to dedicate all of our efforts every day to patients with collagen 6-related dystrophy around the world, to our really our motivation for all of our efforts. I'm happy to take any questions you may have.
Wonderful, Regan. That was great. Thank you very much. We have a couple of questions in the chat box. I don't know whether you can see them. Or, yeah.
I can, yes, exactly. Great. So if any genetic predictor or variable, yeah, great question. So I would say definitely recessive loss of function patients. We know they're not going to produce any collagen 6. We know it's going to be a severe Ulrich and general muscular dystrophy. We also know the glycine variants can be more intermediate. Often the glycine variants, compound heterozygous, even the ones that are not completely null, can be often more severe. The complicated thing is some of the Bethlehem patients have post-TH domain variants that are recessive, that are milder. So it's really complex to predict. We can predict with the intron 11. And you're saying here, if the intronic variant is diagnosed with, yes. So actually, a lot of the patients in our international cohort were found on whole exome sequencing. before whole exome was clinically available, we were making sure all the clinical labs were doing amplification of that region, for the deep intronic variants, so intron 11 amplification. But now, actually, most whole exome sequencing clinicals reporting it, as well as whole genome. CPK is actually not high. It's almost usually normal, maybe a little high, maybe slightly over the reference range, but it's often normal, so it's not a hint. We have a patient with classic Ulrich phenotype, muscle biopsy, IHC shows COL6 stain negative, trio exome negative, whole genome solo in blood was negative. Oh, wow. This variant is novel without any other. So you're looking at 432. So that could be it. So we are seeing, that's interesting. Is that 119 or is it 1119? Because we're seeing some other intronic variants. I can check that one. I don't know if Dr. Modani's on. It's possible that could be it. Oh yeah, 1119. Perfect. Thank you. Okay, so we'll look. Yeah, I'll look at that one. We are seeing further, not as frequent as the one I mentioned, the deep intronic variant. So not as frequent as the 930 plus 189, but there are other ones that are coming out. If it's a clinical picture and you have the muscle biopsy, if the stain is negative, it's interesting. Often it's decreased. Yeah, it's very interesting. If you have the opportunity to do muscle imaging, ultrasound or MRI, that's also helpful. You could do RNA sequencing on muscle tissue. Yes, we've also done RNA sequencing on skin, but muscle would be ideal. So if you could do that, that would be great. And then digeric inheritance, exactly. Yes, we have
There's
not.
Yeah. There's another question about a CK. Are they always high?
No.
And to which extent can they be high?
Great question. So I think the highest I've seen would be around in the Bethlehem patients that are ambulant. I've seen 300, 400. But in the Ulrich patients, intermediate, it's typically normal. Maybe if the reference range goes to 120, it could be 122, 128. But I mean, nothing striking, never in the thousands. So you're getting an SCK in the thousands. It's not collagen-6-related dystrophy, unless they were tackled and they're playing wrestling, maybe after activity. But there's not. Typically, it's normal or a little bit high, 200s, 300s, 400 max in Bethlehem patients, but typically normal in Ulrich intermediate.
Okay. Anne asks whether digenic inheritance has not been noted, as you mentioned.
Yeah, that's right. That's right. So
is it only with the 3 collagen 6 genes, or could
exactly.
they be other digenic mechanisms?
We've not seen that exactly. So, so amongst the 3 collagen 6 genes, alpha 1, 2, and 3, it's not uncommon for people to come back from a whole genome with multiple variants in collagen 6. It's common to have variants in collagen 6. But I'd say put your clinician glasses on and say, like, did I think COL6 before I sequence this patient? If you didn't think COL6 and it's not those variants, I use Leiden open variant database a lot, but we haven't seen digenic. It's always going to be in either the alpha 1, alpha 2, alpha 3 genes. The other collagen 6 genes have not been implicated in COL6-related dystrophy. Yeah. And then COL6 and COL12. So COL12 is also very commonly has many, many variants in it. So it's hard for us because patients will reach out and say, I have a variant in COL12. We have to ask them, what's your phenotype? Yes, recessive COL12 can be severe, much more of a connective tissue phenotype. I have kind of hypertrophic gums and severe hyperlaxity. Dominant COL12 usually has to be in the TH domain. So there's a certain region of the gene COL12 where we're going to have, if it's de novo and it's a certain region, yes, in the right clinical setting. But again, you're going to hear a lot of people say, I think I have COL12 myopathy. If you didn't think that clinically before you saw the variant, probably not. So there are overlaps more with the recessive. The recessive is much more severe from a connective tissue perspective. And we've published on this as well as the team in Newcastle.
Okay, so there was a question about specifically muscle for MRI, just whole body.
I would say actually hips to ankles. T1 axial is all you really need. Hips to ankles, the Eugenia Mercury, protocol, 45 minutes in and out of the, unsedated. Ideally, we don't do them sedated here. Hips to ankles, T1 axial, you'll get the pattern. If you have an ultrasound probe, you can borrow one in the hospital, put the probe on the quads. That central cloud phenomenon is quite prominent. It's less prominent as the disease progresses. But it's usually very, very, very helpful. You do not need whole body.
And I know that you're using ultrasound routinely at NIH. So would it be useful in the context of collagen 6 deficiency to see any specificity, or as suggested by Vinita, sorry,
Yeah.
the possibility of diaphragm ultrasound, which sounds a little
Yeah,
difficult?
it's very hard to do a diaphragmatic ultrasound. What I was showing, I don't know if there's any time, I'm just gonna see if I can just show this quickly again. What I was showing was we call it in vivo MRI. So these are kids
Yeah,
we put in the scanner, we
which
had them
is
do deep
even more
breathing.
sophisticated anyway.
Yeah, it is hard to do that in children that can't be in the scanner and they have to cooperate. It's hard to put a child in the scanner with collagen 6 was a weak diaphragm. So that's always a consideration. But I would say your surrogate measure is that upright and supine forced vital capacity. Again, if upright's at 50% or less, they're definitely hyperventilating. The ORDI patients, when they go from upright to supine, it could be 50% upright, like 28% supine, profound diaphragmatic weakness. That's why when they're sleeping, they need to be a non-invasive ventilation.
Yeah. One question from me. Given the Indian context, I mean, I do remember that Ulrich muscular dystrophy in particular is quite common. It's been reported many times, especially in Bangalore at NIMHANS by Professor Nalini. And my question is, in settings where consanguinity is very high, are we expecting more autosomal recessive cases than de novo dominant forms? That's the
Great.
first question. The second question is it because you mentioned the Cure CMD patient group, which is absolutely great. I guess they have a international registry for collagen 6
Oh,
patients,
yes,
right?
I should mention that.
And
Yeah, so
Indian participants can join or families, or is it self-reported registries?
I'm putting
Because
that
I
in.
think it would
Yep,
be, we're talking about hundreds, if
yep.
not thousands of people in India, I think, having this disease because it's, as you
Yes,
said,
I just put it in the chat. So the CMDIR, the Congenital Muscle Disease International Registry, I should have plugged that. It's so important. So anyone who's genetically confirmed for the family to at least get the genetic testing report in the registry. Registry is kind of long for all the data, but at least get in the genetic testing result because it's helpful for us to say how many patients currently in the world have this variant or that variant. So that's really important. In the question of the recessive, more common and consanguineous areas, it's very interesting. The most prevalent is this dominant, de novo dominant, even the intron 11, it's always de novo dominant. So we do have one homozygous COL6 alpha 2 variant seen in Syria and Sephardic Jewish population that we're seeing recurrent homozygous. Beyond that, we've not seen really population-specific variants or more common in consanguineous. But your point is very well taken. We've always been very proud in the collagen 6 research consortium that it's the most common congenital muscular dystrophy. Sometimes they say Lambda 2 is close, but really most common would be COL6, all takers, Bethlehem, intermediate, Ulrich. Most common being, again, like 0.9 per 100,000, but most common amongst the CMDs.
Okay. Great. I think there are no more questions, and it's a bit late in India, at least, because there must be around 6 or 9 or 10 p.m., so it's a little late. Anne, would you like to close the session? You're online.
No, and just vote of thanks and thank you as usual for the fantastic talk. And thank you for Dr. Anduni for the
You're
really
welcome.
good moderating, picking up
Oh,
the questions and asking questions on behalf of India.
yeah, no, I mean, because it's relevant. I mean, you've got so many cases around, and if any clinical trial is organized someday worldwide, you should apply to be a clinical trial site, definitely.
Oh, 100%. I was going to say also there's a very active patient group, the COL6 group via Cure CMD. I'll put it in the chat. Cure CMD's COL6 group is highly social and highly active and very warm and welcoming. To tell families to go there, I should also end with saying that we don't know why, but most of these affected individuals are highly social and also highly intelligent. We looked at the IQs are typically, especially the older patients, we don't know why. IQ is most typically over 140. So a lot of them have PhDs. And so it's a very articulate population. So oftentimes walk into the clinic room and they're just from their magnetic personality and their intellect alone, you're thinking, is this COL6? And you see the contractures. That's also a clinical hint, but a very active patient group that are very welcoming.
Okay.
So thank you. Sophia is also there, huh? Regan, Sophia is there.
Oh,
Hi,
hello,
Sophia.
Sophia. Another dear friend from London. Thank you.
Okay, bye-bye.
Okay.
Till we
Thank you
Thank
so
you.
much, both
return.
of you. Thank
Thank
you.
you.
Okay,
Take
then
care.
bye.
Thank you. Bye-bye.